Record. I think it's a good talk.
Okay, so I think we start recording. So you're
Okay, let's get started, guys. Thank you very much for inviting me to this week's presentation on our grand round, and I'm going to present a case of sexual hallucinations in an older person. This was the patient I was looking after on a home visit, but more about it in a minute. So let's get started. Okay, so it's a 91-year-old lady who was admitted to hospital with deterioration for history of deterioration for about 18 months. She has had recurrent hospital admissions, transferred eventually to a nursing home after a very, very long inpatient stay. She did not respond to hospital treatments. Most recent admission was with paracetamol overdose. During the 106-day admission on medical wards, she was seen by every specialty possible, neurologists, geriatricians, and the various diagnoses were proposed to her symptoms. She did have a history of epilepsy, so people were thinking whether she's having seizures, infections, UTIs, delirium, depression. Mental health team been to see her a lot as well. So what were those symptoms? She exhibited quite an aggressive behavior, shouting, screaming, throwing cups of hot tea at the staff, scratching, punching the nurse and staff. And during the long hospitalization, these behaviors never actually improved. You would expect someone with delirium, you treat the underlying infection and the symptoms get better. In her case, they never actually got better. And she was discharged like this to the nursing home, and a nursing home started complaining to the family, saying that, remember guys, nursing homes are businesses, so they have to care for other residents as well. And she was very abusive, shouting, screaming, inappropriate language, and was too loud. So the family was asked by the nursing home manager to get her out. Basically, they were evicting her from the nursing home, and the family was given just 30 days to get her out and find another home. At that stage, the family involved me for a second or third or 10th person's opinion, who knows, to see if there is anything else can be done about her presentation, because they were convinced that we are maybe missing something and this is not just delirium dementia. All right. So current symptoms, when I did my assessment, very labile mood and poverty of speech. So 1 minute she was smiling and attempting a laugh, and then within seconds she was crying and screaming and shouting. Very poor memory was the feedback from the nursing home managers. Hallucinations, she was having auditory and visual hallucinations, and as well as somatic hallucinations. She was feeling people touching her. Her hallucinations mainly were of three men. She was quite consistent. She was seeing these three men coming into her room. One of the men was called Malcolm, and they were having sex. And she even admitted to me that she was enjoying every second of it, and was quite happy to see this man coming into her room. So the somatic hallucinations, she was feeling the intercourse and was giving me great details of how enjoyable it was. Delusions were there as well, very poor sleep, agitated during nights, and she was also continuing to have partial complex seizures once or twice a week. Remember, this patient had a history of seizures. All of these symptoms were present in the hospital as well, and they were put down to delirium after the UTIs and post-ictal state after having those recurrent seizures. Right. So she had neurology review in the hospital, and they diagnosed partial seizures post-ictal state. Psychiatry said that the presentation is secondary to seizures and infections, probably underlying undiagnosed dementia. Social history is extremely important in her case. So she is a divorced lady. She does not smoke, does not consume alcohol, and she is wheelchair bound since 2008. And because she's been wheelchair bound for so long, she was quite able to lead a good quality of life despite her disabilities. She had carers coming 4 times a day, and she also had her son and daughter helping her out. She was visiting a day center 3 times a week, had a circle of friends, and was playing bridge, art classes, music classes. So very good quality of life. However, as the years were going by, she was becoming older. Remember, she is 91 now. She was becoming older, frailer, and unable to deal with her disabilities the way she used to. She was getting doubly incontinent. There were a few episodes of incontinence at the day centers, which embarrassed her a lot. Eventually, she became a recluse. She stopped going to the day centers, became very isolated, very lonely, and it is at that point that family noticed that her behavior started changing, and she started getting quite strange. She started accusing her carers of stealing things. She was calling police with accusations of about the carers. So the family was getting a bit worried about her at that stage. Now, family history in someone presenting with mental health concerns is, of course, very important. And it turned out that her father spent 30 years in a mental institution after attempting a suicide, where he died eventually. Now, why was she wheelchair bound, you might ask? Well, she had a left frontoparietal meningioma surgery in 2001, which went horribly wrong and was complicated by intracerebral hemorrhage, resulting in the right-sided hemiplegia. And she also had deterioration of her voice over the course of 2-3 years as well. Now, her current medications are pre-morbidly, that is before she even went to hospital, citalopram, clopidogrel, lansoprazole, tavaprost, and dorzolamide eye drops. She was also on Senna, phenytoin, and lamotrigine for post-brain surgery seizures. And the hospital started her on quetiapine, 25 milligrams twice a day, for her odd behaviors as a treatment of delirium. She was also on paracetamol, PRN. Now, on physical exam, I did not find much to talk about. Her vitals were fine. She was overweight, obese, BMI 35. Otherwise, lungs, normal vesicular sound, so nothing really much to talk about. Abdomen was soft and non-tender. She is doubly incontinent. The legs, evidence of a quite marked lipodermatosclerosis. A neurological examination revealed residual right-sided hemiplegia with increased tone and contractures. Now, guys, at this point, and we don't have an audience response system, but you can start typing quickly, and Stephen will tell me what you are guys doing there and what you think about this case. Now, at this point, I'm this percent sure what is going on. So what do you think the diagnosis is here? So 0% including knowing what is lipodermatosclerosis is, 25%, 50%, or maybe you are 75% sure of the diagnosis here, 100%. Is anything coming there, Stephen?
Well, I can definitely say from me it's 0%.
Okay.
But we'll see how guys go. But I mean, this is it's weird.
Okay,
Definitely not something I normally see in practice.
Okay.
So
Let's see what's going on then. So lipodermatosclerosis, by the way, it's a discoloration of the skin you see in patients with chronic venous insufficiency. These patients every now and again come with extremely red legs to hospital, and you start pumping them up with flucloxacillin. But of course, it's not cellulitis. It's a chronic venous insufficiency. The increased pressure in the veins lead to the blood seeping out into the soft tissues, and hemosiderin deposition gives you that appearance of the legs. Every now and again, they go red, hot, and tender, and that's an acute venous eczema exacerbation, which needs steroid creams, the likes of betnavate, and not IV flucloxacillin. Right, well, coming back to our patient, at this point, what are you going to do? Well, probably a little bit of most of a general blood test for dementia and vasculitis, definitely. Chest X-ray, maybe CT or MRI. She had a bleed in the past. Maybe she has a recurrent tumor. Neuropsychometric testing, so that is MMSE, Addenbrook's geriatric depression scale. Get more information about so-called hallucinations. Maybe, guys, you want to get her back to hospital for another 160 days. I mean, more investigations, lumbar puncture, maybe. What do you think?
I gotta say, and I'm not a big fan of lumbar punctures. I try to do a lot more homework before I go there, but I mean, in cases where I think it's encephalitis, that makes sense. And a lot of the other attendees have said they don't know what's going on, 0%. But I think what you're suggesting about doing a general blood work and
General blood
imaging,
work. Yeah, let's start with a general blood work, general sort of chest x-ray and things like that. So we did not admit her to hospital, but what we did is through the GP, we did number of tests. Some of the tests I just got from the hospital. Her chest x-ray just before the discharge from hospital did not show anything major to worry about. She did have brain scan, which showed the gliosis post-surgery, but there wasn't any new tumor or anything like that. Her laboratory studies were more or less satisfactory. Her vasculitic screen came back negative, and dementia screen did not show anything major to worry about. She was a bit anemic, but that doesn't come as a surprise after a 3 months hospital admission. Urine cultures did show E. coli, which was treated on a number of occasions, and as I said, CT just showed post-surgical gliosis. Now, let's go into these hallucinations a little bit. Remember, guys, they have been going on for 18 months, so it would be a bit unusual for this to be anything super acute. She hears and sees the same people in her room. These are 3 men. One of them is called Malcolm. They are somatic. She feels them touching her, having a sexual intercourse, and as I said, she rather enjoys the experience on most of the occasions. So these details only came to light for the first time during my assessment. 3 months in hospital, this history was not actually presented to healthcare professionals, maybe because they didn't ask the right questions. In hospital, this was attributed to UTIs and seizures. Now, she also had paranoid delusions. So we have hallucinations, delusions. Now, over the last 18 months, she believed there were people in her home, peering around the door, stealing her belongings, and she was accusing caregivers of stealing her money and her food. Now, she also strongly believed that her son was killed, and she was the killer. Malcolm and her killed her son, and she got hold of a telephone about a week ago before I saw her and called 999 to tell the police that she and someone called Malcolm murdered her son. So she felt great responsibility for the death of her son, and during my consultation with me, she burst into tears, and then within seconds she was smiling again. So quite a labile mood. Now, disorganization, her speech was completely disconnected, flight of thoughts, and she was jumping from one subject to another, so it was very difficult to get her back into the conversation and continue on the same topic before moving on to the next one. Now, what do we have then? We have complex visual hallucinations and differential diagnosis in a younger people. Now, I'm not a psychiatrist, guys. I'm a geriatrician, but while searching the subject, I looked into what are the most common differentials in the younger people that would be, and that's inefficient sleep and substance abuse are the top 2 reasons for visual hallucinations. I actually experienced the first one myself. In the first 4 months of me having little Anya, I didn't sleep at all, and I had such a vivid visual hallucinations. I was seeing my dad, who passed away 10 years ago to brain cancer, and my auntie. So it can be quite scary. Now, schizophrenia, schizoaffective disorder, mood disorders with psychotic features, PTSD, re-experiencing of the episode which led to the PTSD can be quite scary. PTSD patients suffer a lot with nightmares because of this. And then hysteric conversion, malingering is mentioned as well.
Can I ask a quick question before you go on?
Yeah.
What's the rough prevalence of substance abuse in Yalda?
I don't have a figure from the top of my mind, but I will definitely look that up for you.
Okay, thank you.
So complex visual hallucinations, let's have a look at differential diagnosis in older people. So schizophrenia and schizoaffective disorders are common in older adults as well. Mood disorder with psychotic features. Now, we see that in our clinical practice quite a lot when the person is experiencing a major depressive episode, and if untreated for a long time, they do develop psychosis with depression. Peduncular hallucinosis associated with lesions in midbrain. So some of our patients who have stroke, mainly it's a vascular lesion, strokes in midbrain, pons, thalamus, can go on and have peduncular hallucinosis, and that is very vivid visual hallucinations. These ones are not that scary because usually patients can differentiate between the reality and hallucinations. Parkinson's disease, Lewy body dementia. So your Lewy body dementia, the triad is that obviously dementia, Parkinsonism, and hallucinations could be your differential as well. Charles Bonnet syndrome, when the eyesight decreases and then the brain starts compensating for that, and people start having visual hallucinations. These are the most common differential diagnosis would be in older adults. What is not visual hallucinations are optical illusions, and I'm sure you might have a lot of entertaining apps for optical illusions. Now that's definitely not hallucinations. Okay, so what you are going to do at this point, remember she's on citalopram and quetiapine 25 milligrams twice a day. Are you going to change her depression treatment, change her seizure treatment, increase the dose of quetiapine, refer back to psychiatry for ECT? Remember, during the 3 months hospital admission, she was seen by psychiatrists many, many times. Or shall we refer her to sex therapists, as my 18-year-old declared that there is no sex after the age of 30, so this is clearly abnormal and should be addressed. So what do you guys think?
That's an interesting choice there. We'll wait to see if anyone. Let me just ask, guys. Please do try to contribute. I think the more interaction we have, the more interesting. So you can text in your replies. That would be really useful. So
we can have a look at your replies.
We've got one. Someone said option 3, which is increase the
dose of quetiapine.
My question is, well, have we got a sex therapist you can refer to?
No, that's an interesting one. Yes, that's my second job, Stephen.
Someone's written here social prescribing. Consider social prescribing.
Okay, so that is addressing that she is isolated, lonely, and that's such a relevant topic, actually. Thank you for mentioning that, because I saw and treated this lady before the COVID pandemic, but with the COVID pandemic, we're in the middle of it. We are, of course, going to deal with a lot of mental health issues, both in young and older adults, through social isolation and loneliness, which was bad as it is in my older patients, but it is now even worse. Right, so coming now to differential diagnosis, the hallucinations could be consistent with Alzheimer's dementia, consistent with another form of dementia. Remember, guys, she had definitely some frontal signs, very odd behavior, sexualizing her, sexual hallucinations, swearing, using inappropriate language. So there is frontotemporal signs. Could it be CJD? More consistent with major psychiatric disorder, that is, could there be a loneliness leading to major depressive episode with psychosis? Most consistent with hysteria, she's making it all up. It is definitely disturbing that she called 999 and not even on a single occasion. She, whenever she could get hold of the phone, she was dialing 999. So various possibilities. Okay. By the way, did you know that the 999 emergency number, we only have it in Great Britain? In the US, Canada, a few Central and South American countries, it's 911. Interestingly, in Chad, the emergency number for ambulance, try to remember, just in case if you are in Chad, 225-14242 or 225-11237. I hope you remembered. It's interesting to have a look at the average life expectancy in Chad, which is overall life expectancy 51 years old. I wonder whether it's anything to do with the emergency number. Something to think about. Right, coming back to our patient. So I think the most unusual aspects in this case are that she's 91 and having highly sexual hallucinations, disorganized speech and highly sexual hallucinations, physically aggressive behavior and highly sexual hallucinations, a prolonged 106-day hospitalization and highly sexual hallucinations. And Stephen, did I mention those highly sexual hallucinations?
I think you might have.
Oh, yeah, okay, all right, okay. Right, so a diagnostic test was performed. Confusion assessment method, CAM, is a test for delirium. So it's an old, well-validated tool for delirium assessment, which should be used on regular basis. Here at Conquest Hospital, we are using CAM, we are using a 4AT, which is in our Clarkin Proforma. Addenbrook's cognitive examination. So for dementia testing, we're using MMSC, which is 30 questions questionnaire for dementia. But guys, did you know that MMSC actually doesn't have a single question testing your frontal lobes? So if your patient is presenting with frontotemporal symptoms and has a underlying frontotemporal dementia, you will totally miss it with MMSC. So in my clinics, I tend to use Addenbrook's cognitive examination, which is 100 questions questionnaire for diagnosing dementia, and it tests in all the cognitive domains, including the frontal lobes, executive functioning of the brain. GDS is geriatric depression scale. Maybe we should do brain biopsy, and maybe we should ask her why she actually took paracetamol overdose. Did it cross anybody's mind at this stage, or we are so used to these paracetamol overdoses that as time goes by, you become immune to this? Well, another paracetamol overdose, NAC and LFTs and INR, and so you know we lose touch actually what is happening with the patients. But we will come back to that. So here are her results. She was not delirious, so we can put that to one side. On MMSC, and because of her hemiplegia, she couldn't perform all questions. She tested 23 out of 28. Interestingly, she did not lose a single point on memory. Her memory was perfect. On Addenbrook's test, she scored 69 out of 90. Again, because of her disability, because of the brain bleed and meningioma surgery, she couldn't perform all the tasks. But she had major problems with speech, verbal fluency, severe problems with the frontal lobes, executive functioning, but preserved memory. And she had mild depression on geriatric depression scale. So now then, we are actually coming to the point. Why did you take? I asked her, why did you take the paracetamol overdose? It seems like an obvious question to ask on admission, but again, it's something which was overlooked. Nobody asked her that question. It turned out that while she was in hospital, the overdose was attributed to loneliness, social isolation, and depression, which is not the wrong thing to do, which majority of overdoses are due to this reason. But in her case, it was actually different. On the day she took paracetamol overdose, she again had the 3 men in her room. And whereas usually she enjoyed sexual intercourse with these men, on this occasion, she did not want to have sex, and they raped her in her hallucinations, and she was hearing really bad voices asking her to kill her son. And on that particular day, it was her being raped which led to paracetamol overdose. Any last guesses, guys? Any last guesses? Do you want to guess who this is, Stephen, without looking on my screen?
No, I don't know who that is. No, I would say, I have to say, honestly, the one thing that also part me goes is, do I call the police? Am I actually, sometimes it's very easy to do hallucinations, but is there element of truth? Someone actually getting into it. But no, I'm not sure who this is, though.
Right, guys, well, let's carry on with the case. I'm about to reveal the diagnosis, and this is the woman I'm actually gonna miss quite a lot. It's our ex-first lady. Right, well, let's move on. Now, her diagnosis is very late onset schizophrenia like psychosis. Okay, VLOSLP. So it did take many hours of my time putting the story together, doing my literature research. The first consultation alone took 3 hours going and looking through things. And she was fitting the criteria for a very late onset schizophrenia like psychosis. So it's a schizophrenia in the elderly has been largely disregarded by researchers, unfortunately, as over 90% of published papers on schizophrenia excluded elderly people altogether. So no wonder we miss these people. Criteria is onset of symptoms in individuals older than 60, presence of fantastic persecutory, referential, grandiose delusions without hallucinations, absence of primary dementia, absence of, so I felt on the psychometric assessment that her difficulties, which we were observing with frontal lobes and speech problems, were secondary to the brain bleed and the brain gliosis, major meningioma she had, but she had completely intact memory. Other domains were fine. So she was fitting the criteria. Late onset schizophrenia. So it develops, we do have, despite this, approximately 20, almost quarter of patients with schizophrenia develop the illness after the age of 40, and persons with symptom onset after the age of 60, roughly about 4%, considered to have late onset schizophrenia. So it's not something you are going to see on daily basis in your clinical practice, but when you guys have patients coming in and out, these unusual behaviors, not getting better with antibiotics and various treatments, you have to become suspicious. So overall prevalence, as I said, a small 0.10 to 0.5%, and majority of the neuropsychiatric presentations we are going to have are going to be due to dementia, depression, delirium, but please do think of late onset schizophrenia in our elderly population. So it's more common in women than in men, and there is evidence of sex differences in brain volume loss, and dopamine receptor numbers have been blamed for this difference, and it is possibly linked to estrogen loss in women. And a number of trials have been done here, and many other biological findings. I'm not going to go into that, but when it comes to dopamine receptors, the elderly people with schizophrenia may also have more dopamine receptors than age matched normal controls. And this could be the reason, guys, why when it's very well known fact, when you are treating a newly diagnosed patient with Parkinson's disease, when you are starting them on levodopa, in elderly patients, you have to start very slow. I give the smallest dose possible, once a day for a week, then increase to twice a day from week 2, and so on. And the reason being is because if you give too much levodopa in elderly, they go completely psychotic and delirious and develop psychiatric psychosis. So a lot to do with dopamine receptors. Clinical presentation, I think we can summarize here on the right-hand side, late onset patients. The clinical presentation of late and early onset schizophrenia is more or less similar, largely similar. The late onset patients are more likely, compared to the early onset counterparts, to have visual, tactile hallucinations, abusive and accusatory auditory hallucinations, third-person running commentary, and persecutory delusions. This is another interesting fact which I found during my research. The treatment for late onset schizophrenia, again, it's the same as you would treat a younger person with schizophrenia, and that is antipsychotics. However, there have been a number of trials, observational, investigational studies done where they try to stimulate estrogen receptors with the likes of estradiol. And they found that the schizophrenia symptoms were getting much better. So they said whether we see more schizophrenia, very late onset schizophrenia in postmenopausal women. So they hypothesized whether estrogen actually protects women. And we see clinical studies have shown higher psychotic symptoms in perimenopausal women, in women at the low estrogen phase of menstrual cycle as well. Some ladies might have experienced it in themselves during the menstrual cycle, becoming a bit different. So there you go. Now, we are not routinely giving estradiol to as a treatment at the moment, and the studies are ongoing on this. But it's a very, very interesting area to explore. So what did I do with my patient? I titrated her quetiapine. So some of you who went for option 3 in the treatment, increase the dose of quetiapine, were absolutely right. Well done to you. I very slowly titrated her quetiapine. Remember, her original dose was 25 milligram twice a day. We went all the way up to 200 milligrams twice a day by increasing by 25 milligrams a week. I experimented with citalopram because there is no doubt there was also underlying depression, and you know, various mental health conditions can go hand in hand. It's like depression and dementia. There are two conditions which almost always accompany each other. So I changed her from sertraline, subsequently changed to mirtazapine to sort of help her nighttime agitation, and her behavior changed. The nursing home kept a behavior chart, and there were no episodes of challenging behavior a month after starting the treatment. Her life transformed. She started spending time in the lounge with other residents, enjoyed watching TV. There was none of that screaming, shouting, and throwing things around. Taken out in a wheelchair by children for walks around the home. The home was very nice, very, very nice home. Stopped hallucinations. However, there is one thing remained. She still had that strong belief and guilt that she killed her son. And whenever he was coming to visit her, she always greeted him, I thought you were dead. I thought I killed you. So, and every time she was seeing him, she was crying, not believing that her son is alive. So that never went away. As the time went by, remember she was 91 years old when she presented to me. As the time went by and I observed her for about a year, her frailty was getting worse. She was having recurrent UTIs, multiple courses of antibiotics. I did an extensive future care planning with the GP, with the family, with the patient, and we all agreed that she's not going back to hospital. And GP and myself maintained her in care home as long as we could. And then in the last 2 weeks of her life, she was under care of amazing palliative care team, and she died very peacefully at her nursing home. But what this enabled, the diagnosis and treatment enabled her to have at least 6 months of quality life with her family in the care home. All right, guys, so that's the presentation, and hopefully I left a little bit of time for questions. Before we go into questions, may I draw your attention to my Instagram page, which is, if you are still not part of my Instagram, join me at dr.Elena Mucci. I promise to keep you entertained in the years to come. There is a lot of educational material. most importantly, I'd like to draw, if you do join, can you check my IGTV videos? I've just uploaded 45 minutes video podcast on frailty. This was collaborative work with the Alzheimer's association from California, from San Francisco. We did this a couple of months ago. We just got the podcast from the editors and I uploaded it. It will be very useful for junior doctors, for everyone really. It's just how to communicate frailty to the families. It's called Frailty, Is It Even a Medical Condition? The same San Francisco group with the same organization, we are going to do monthly podcasts. The next one is on polypharmacy and medication management, and there will be one coming every month. But there is plenty of stuff to keep you entertained apart from that.
Elena, I think it's great. I think in a way we hope more consultants can get more involved with electronic social media. I think that's fantastic, actually.
Mm-hmm.
I guess I have one thing to ask. For the junior doctors, for their benefit, what would your top 3 take-home messages be from this presentation? What would you want them to take home that would improve the clinical practice in this setting?
Okay, so because we are in 21st century and we have all these fancy blood tests and investigations, I do find that the basic clinical history taken and examination is now becoming obsolete. So my first take-home message is, in geriatric patients especially, do not forget. In fact, if you want to challenge yourself, when you are clocking patients, you go and look at the chest x-ray, look at bloods, look at everything, and then you go and clock the patient. Why don't you challenge yourself? Don't look at those bloods, don't look at the chest x-ray. Go and do de novo history taken and clinical examination, and then compare your signs to the signs of the chest x-ray and blood tests and come up with a clinical diagnosis. That's number one. Number two, the confusion. So the word confusion is so confusing. Whenever you come across confused elderly patient, please commit yourself to a diagnosis of some sort. Are you dealing with delirium? Is this maybe alcohol intoxication? Or are we dealing with dementia? Is this chronic dementia? Or maybe it is psychosis to do with depression. So try to have a differential diagnosis. Don't just say she came with confusion. So that's number two. And number three, of course, guys, as a geriatrician, I'm a physician, I'm not a psychiatrist, but 50% of my time, 50% of my patients have mental health problems, mental health diseases. As you know, physical problems lead to mental, especially chronic long-term physical problems, strokes, heart attacks. We all know statistics, the rate of mental health illnesses after bypass surgery, intensive care stay. I mean, wait until pandemic is over. There is a mental health pandemic coming our way. So do mental health, read around mental health, so we can diagnose correctly, treat appropriately, but also, as I said, pandemic is over, you will have another pandemic coming your way. So we are equipped with knowledge and experience to address mental health issues in our COVID surviving patients.
Thanks, Elena. That's fantastic. I have one last question. How much would you involve an old age psychiatrist with titrating up the type? Would you be comfortable doing it yourself?
Now, that's a brilliant question. Of course, you have to have the experience and treat enough patients to be able to titrate this drug. I am personally very comfortable titrating, treating, diagnosing myself. I very rarely refer to an old age psychiatrist. The reason being, Stephen, is because they're extremely busy people. They come to the ward, they see the patient for 10, 15 minutes. You are the one looking after the patient for weeks and weeks and weeks. And then we rely on someone who has seen the patient for 10 minutes to give you a diagnosis and treatment. It's almost unfair on the psychiatrist, unless, of course, you have that relationship where they come in every day or 2-3 times a week, observe the patients and help you. So we need our old age psychiatrists, but I think I'm coming to the point where we all need to become partially psychiatrists ourselves, because there is so much mental health illness out there.
Thank you, Elena. That's fantastic. And I think, guys, that's a fantastic grand presentation of sexual hallucinations and old age schizophrenia. So we're going to draw this session to a close now. But if you have any last minute questions, please put them on the text group. If not, in a minute or so, I'll close the group. But that's fantastic.
Okay, thank you very much. Thank you, guys. Bye bye.